Stopping ejaculation entirely does not damage the body, but it does remove certain measurable benefits. Research has linked to regular activity. Today, we're reviewing what actually happens hormonally and physically when elderly men stop altogether, whether by choice, circumstance, or health changes based on published research rather than assumption. The most researched area involves prostate health. A large, frequently cited population study found men reporting higher ejaculation frequency across adulthood had a measurably lower association with prostate cancer risk later in life compared to men with consistently lower frequency. Evidence level moderate based on large observational data rather than randomized trials. What matters more than any specific number is avoiding very long-term sustained absence over years rather than shorter gaps. A temporary pause for whatever reason isn't what this research is describing as a concern. It's the sustained long-term pattern over many years that shows the more consistent association. Before continuing, a brief note: stopping entirely, whether due to health changes, medication, relationship circumstances, or personal choice, is not itself dangerous. What follows addresses research-documented associations, not a claim that anyone is obligated to maintain any specific pattern. A common assumption is that stopping raises testosterone significantly over time. Evidence level not well supported. Some short-term studies found a modest, temporary increase after several days of abstinence, but this effect is small and doesn't translate into a meaningfully different long-term hormonal baseline. Testosterone production is governed by a feedback system involving the brain and testes, not primarily by ejaculation frequency itself. A frequently asked question involves whether stopping causes tissue changes or use it or lose it decline. Nocturnal erections, which occur automatically during REM sleep, continue regardless of a man's activity level, meaning erectile tissue generally continues receiving regular blood flow even during extended periods without ejaculation. This means healthy men experiencing extended absence for any reason generally don't experience the tissue level decline sometimes implied online, provided underlying vascular and neurological health remains otherwise normal. Men with conditions affecting nocturnal erections specifically, such as significant sleep apnea, reducing REM sleep, are a different, more clinically relevant case, where addressing the underlying condition matters more than absence itself. We're now roughly halfway through, and this is where population research gives way to more individual factors, mood, medication, and underlying health, that matter more for elderly men specifically than for younger populations. Ejaculation triggers oxytocin and prolactin release, both associated with measurable stress reduction and mood improvement afterward. Extended absence removes this specific input, though effects vary considerably between individuals. Some men notice little difference, particularly with other stress outlets, exercise, social connection, active. Others notice increased irritability or restlessness, more likely in men already managing chronic stress from other sources with fewer alternative coping mechanisms in place. The prolactin release following ejaculation is associated with improved sleep onset for many men. During extended absence, some men notice a subtle change in falling asleep, though this effect is generally modest compared to other, larger factors affecting sleep quality: stress, screen exposure, caffeine. Before continuing, if you want a broader framework connecting hormonal health, sleep, and vitality after 40, Dr. Emily Carter's guide, The Iron Age, the complete blueprint to reclaiming testosterone strength and vitality after 40, covers testosterone, strength, energy, and vitality across 9 focused chapters in a concise 14-page format. It's priced at $49.99 with the link provided with this video. It's educational, not a replacement for medical care, but it offers a clear framework for understanding these interconnected systems. For elderly men, reduced frequency or interest is often circumstantial, health changes, medication, relationship status, rather than concerning on its own. However, a change accompanied by other symptoms, fatigue, low mood, reduced motivation, warrants attention, since it may reflect low testosterone, depression, or an underlying medical condition rather than simply circumstance. Particularly worth checking rather than assuming age alone explains everything. Several conditions common in elderly men directly affect this area and deserve attention rather than assumption. Prostate surgery, depending on type, can affect function. Certain medications, particularly some blood pressure drugs and antidepressants, are documented to reduce interest or function as a side effect. Diabetes affects nerve and blood vessel function relevant here. Any of these, when identified as the cause, often have management options worth discussing directly with a doctor rather than assuming permanent, unaddressable decline. Bringing this together, stopping entirely is not physically dangerous and does not meaningfully raise testosterone or cause tissue damage in most cases, since nocturnal erections continue providing regular tissue activity regardless. Extended absence may affect mood and stress regulation for some men, though this varies considerably by individual. The clearest evidence-supported concern relates to very long-term sustained absence over years, specifically in relation to prostate health research, not shorter-term gaps. A change accompanied by fatigue, low mood, or other symptoms warrants medical evaluation rather than assumption that age explains everything. It's worth distinguishing between elderly men who reduce or stop this activity by personal choice, sometimes tied to reduced interest with age, relationship changes, or simple preference, and those who stop due to a specific health event, prostate surgery, a stroke, a new diagnosis, or a new medication. These represent genuinely different situations worth understanding separately, since the underlying cause meaningfully affects what, if anything, is worth addressing medically. Men who reduce activity by choice without any accompanying physical or mood symptoms are generally not experiencing anything requiring medical attention. This reflects normal variation in interest and priorities that occurs across a lifespan, no different in principle from changes in appetite or activity level that many people experience as they age. Men who stop suddenly following a specific health event, however, have a clearer, more identifiable reason worth discussing directly with the relevant specialist, since some causes in this category are genuinely modifiable through medication adjustment, timing changes following surgery, or targeted treatment, while others may require adjusting expectations around a new, different baseline going forward. Since prostate surgery was mentioned as one common cause of sudden change in elderly men, it's worth explaining this connection in more detail since it represents one of the more common, clinically significant scenarios underlying this entire topic for men in this age group. Certain prostate surgeries, particularly radical prostatectomy performed for prostate cancer, can affect the nerves and blood vessels responsible for erectile function, sometimes causing a temporary or in some cases more lasting change depending on the specific surgical approach, whether nerve-sparing techniques were used, and individual healing patterns. This is a well-documented, expected possible outcome discussed directly between patients and their surgical team as part of standard preoperative counseling, not an unexpected surprise arising afterward. For men who've had this type of surgery, function sometimes improves gradually over months to a couple of years following the procedure as nerve tissue heals, particularly with appropriate rehabilitation approaches, sometimes recommended by urologists specifically for this purpose. Other surgical approaches to prostate conditions carry different, sometimes more limited effects on this specific function. This is precisely the kind of detail worth discussing directly, and specifically with the treating urologist rather than assuming a uniform outcome applies to every type of prostate procedure, since the actual effect varies considerably based on the specific surgery performed. Stroke and certain other neurological conditions can affect function through their impact on nerve signaling, and in some cases through effects on mood and motivation more broadly, both relevant to this topic. The specific effect varies considerably depending on which area of the brain or nervous system was affected, meaning generalized statements about stroke and this topic don't apply uniformly to every individual case. For men recovering from stroke, this is a reasonable topic to raise with the neurological or rehabilitation team managing recovery, since it connects to broader recovery goals and quality of life considerations that rehabilitation specialists are generally well equipped to address directly, even though it's not always raised proactively by patients or sometimes by care teams either, reflecting the same broader cultural reluctance to discuss this topic directly that's been noted throughout other videos on this channel. Depression deserves particular attention in this age group since it's both relatively common in elderly populations and frequently underdiagnosed, partly because symptoms in older adults sometimes present differently than the classic presentation, more commonly discussed, less overt sadness, more frequently fatigue, withdrawal, reduced motivation, and diminished interest across previously enjoyed activities generally, this specific area of life included. Reduced interest tied to depression is genuinely treatable through therapy, medication, or a combination approach depending on severity and individual circumstances, meaning it's worth distinguishing from simple, expected age-related change rather than assuming reduced interest automatically reflects normal aging without considering mood as a potential underlying factor. A pattern of reduced interest, specifically accompanied by low mood, reduced enjoyment of other previously valued activities, changes in sleep or appetite, or persistent low energy warrants a conversation about mood specifically, not just this one isolated topic. For elderly men who are widowed, divorced, or otherwise without a current partner, circumstantial absence obviously differs from a partnered man experiencing change within an ongoing relationship. This is worth naming directly, since it's an extremely common situation in this age group that doesn't reflect any physical or hormonal problem at all, simply a change in life circumstances. Research on loneliness and social isolation in elderly populations more broadly finds meaningful associations with both physical and mental health outcomes, independent of this specific topic. For men in this situation, maintaining other forms of social connection and emotional intimacy, friendships, family relationships, community involvement, carries genuine, independently documented health value, worth prioritizing regardless of this specific topic, rather than viewing circumstantial absence in this one area as the primary concern requiring resolution. Given how many medications commonly prescribed to elderly men carry documented effects on this topic, a practical, genuinely useful first step for any man noticing an unexplained change involves requesting a straightforward medication review with a doctor or pharmacist. This involves going through a current medication list specifically to identify any drugs with known effects on function, mood, or hormone levels, several categories of which have already been discussed throughout this video series. This is a low-effort, low-risk starting point that sometimes identifies a straightforward, addressable cause, a specific blood pressure medication, a particular antidepressant, without requiring extensive additional testing. Pharmacists specifically are often an underused resource for this kind of review, since they have detailed knowledge of medication side effect profiles and can flag potential factors worth discussing further with a prescribing doctor. For men pursuing further evaluation, it's worth understanding what basic blood work can and cannot clarify regarding this topic. Testosterone testing provides useful information about hormonal status, though it's worth noting that testosterone naturally declines gradually with age, meaning a modestly lower level isn't automatically abnormal or the definite explanation for any specific change, particularly in men without other symptoms of low testosterone specifically. Thyroid function testing, blood sugar testing, and a general metabolic panel can identify several other relevant treatable factors already discussed throughout this video series. What blood work generally cannot fully capture includes psychological factors like depression or relationship dynamics, meaning a normal set of lab results doesn't rule out these other equally legitimate categories of explanation discussed earlier. A thorough evaluation generally considers blood work alongside a broader conversation about mood, medication, relationship circumstances, and overall health, rather than relying on lab results in isolation. For men who do identify an addressable cause, whether medication-related, hormonal, or related to mood, it's worth setting realistic expectations about what treatment can achieve. Medication adjustments sometimes produce meaningful improvement within weeks. Hormonal treatment, when genuinely indicated based on blood work and symptoms, generally requires a period of months to assess full effect properly. Treatment for depression similarly generally requires a period of weeks to months before full benefit becomes apparent, and may involve some trial and adjustment to find the most effective specific approach for a given individual. None of this represents an instant fix, and setting this expectation clearly from the outset tends to produce better long-term engagement with treatment than expecting immediate dramatic change that doesn't reflect how these systems actually respond to intervention. Stepping back from the specific clinical details discussed throughout this video, it's worth offering a broader perspective on how this topic fits into aging generally. This area of life, like many others, genuinely changes with age for most people, and change itself isn't inherently a problem requiring correction. What matters clinically is distinguishing between expected, normal variation and a change that reflects an underlying, addressable medical or psychological factor worth identifying. Elderly men who approach this topic with the same straightforward, non-catastrophizing attitude they might apply to other age-related health changes, worth understanding, worth mentioning to a doctor if accompanied by other symptoms, but not inherently alarming on its own, tend to navigate this stage of life with considerably less unnecessary anxiety than men who either avoid the topic entirely or interpret every change as a serious problem requiring immediate resolution. For elderly men currently in a relationship experiencing a change in this area, communication with a partner matters considerably for how that change is navigated emotionally, separate from any medical evaluation pursued. Research on long-term couples consistently finds that partners who discuss changes openly, understanding them as a normal, expected part of aging rather than a personal rejection or a sign of declining feeling toward one another, report considerably less relationship strain than couples who avoid the topic and allow assumption or silence to create distance. A partner unaware of an underlying medical cause, a new medication, a health condition, may sometimes misinterpret a change as reduced affection or interest specifically in her, when the actual explanation is entirely unrelated to the relationship itself. Proactively sharing what's actually happening, even briefly, tends to prevent this kind of unnecessary misunderstanding from developing and compounding over time. It's worth addressing a pattern that sometimes develops in men who've become aware of the research and clinical considerations discussed throughout this video. Anxiety-driven, excessive self-monitoring for any sign of change, treating every fluctuation as a potential red flag requiring investigation. Normal variation exists in this area just as it does in appetite, sleep, or energy levels generally, and not every fluctuation reflects a meaningful, medically relevant change. The clinical guidance discussed throughout this video applies most usefully to sustained, meaningful shifts, particularly those accompanied by other symptoms, rather than day-to-day or week-to-week variation, which is entirely normal and expected. Excessive vigilance itself can become a source of anxiety that ironically contributes to the very stress response known to affect this area negatively, creating an unhelpful cycle worth avoiding through a reasonably relaxed rather than hypervigilant approach to monitoring change over time. For elderly men receiving support from family caregivers, particularly those managing more significant health conditions or cognitive changes. It's worth briefly addressing how this topic fits into broader caregiving conversations. This remains a private, personal topic, deserving of the same dignity and discretion at any age, and involvement of family members in this specific conversation should generally be guided by the individual's own comfort level and wishes wherever cognitively possible, rather than assumed as automatically appropriate simply because a caregiving relationship exists. That said, in situations involving significant cognitive decline, where an individual may not be fully able to advocate for themselves medically, caregivers managing overall healthcare coordination may reasonably need general awareness of relevant medication effects or symptoms discussed throughout this video, primarily to ensure comprehensive medical care rather than to monitor this topic specifically in isolation. Within geriatric medicine specifically, quality of life assessment increasingly recognizes this general topic as a legitimate component worth including in comprehensive care, rather than treating it as separate from or less important than other health considerations more traditionally emphasized in care for elderly patients. This reflects a broader, positive shift within geriatric care generally, moving away from an assumption that this topic becomes irrelevant or inappropriate to address once a patient reaches a certain age. Geriatricians and other specialists working with elderly patients increasingly incorporate direct, comfortable questions about this general area into routine health assessments, recognizing its genuine connection to overall well-being, mood, and relationship satisfaction, rather than treating it as a topic patients must raise entirely on their own initiative, given how much cultural reluctance, discussed throughout this video, still surrounds the subject for many patients in this age group specifically. Bringing together the various distinctions discussed throughout this video into a clearer, more consolidated framework, specifically for elderly men and their families navigating this topic. Change that develops gradually over years, without accompanying symptoms like fatigue, low mood, or other physical changes, generally reflects normal, expected variation, not requiring specific medical intervention beyond routine general health care. Change that occurs suddenly, coincides with a new medication or health event, or is accompanied by other symptoms, low mood, fatigue, unexplained physical changes, warrants a specific conversation with a doctor, ideally including a medication review and basic relevant blood work as discussed earlier in this video. And change occurring within a relationship benefits from direct communication with a partner, regardless of whether an underlying medical cause is ultimately identified, simply to prevent unnecessary misunderstanding or emotional distance from developing around a change that may have an entirely non-relational explanation. This general subject deserves the same clinical seriousness, dignity, and freedom from unnecessary embarrassment at 70 or 80 as it does at 30 or 40. The tendency to treat this topic as increasingly inappropriate or irrelevant to discuss as men age reflects cultural discomfort rather than any genuine medical or logical basis, and elderly men deserve exactly the same quality of information, evaluation, and non-judgmental support in this area as any other patient, regardless of age. For elderly men whose blood work confirms genuinely low testosterone alongside relevant symptoms, testosterone replacement therapy sometimes becomes part of the conversation with a doctor. It's worth understanding this isn't a first-line or automatic response simply based on a modestly lower number, since testosterone naturally declines with age, and a mildly lower level without accompanying symptoms often doesn't warrant treatment on its own. Clinical guidelines generally reserve testosterone replacement for men with both consistently low levels on repeated testing and clear relevant symptoms, fatigue, low mood, reduced muscle mass, alongside the changes discussed throughout this video. This treatment carries its own considerations worth discussing directly with a doctor, including effects on prostate health, cardiovascular risk factors, and red blood cell production, meaning it requires ongoing monitoring rather than being a simple, risk-free intervention appropriate for every man with a borderline lab result. Nutrition connects to several threads already discussed throughout this video: testosterone, vascular health, and general energy, worth understanding specifically as it applies to elderly men. Adequate protein intake becomes increasingly important with age to counteract natural muscle loss, which itself connects to metabolic and hormonal health more broadly. Zinc, a nutrient supporting testosterone production, is sometimes deficient in elderly populations due to reduced dietary intake or absorption changes with age, worth checking through blood work if broader hormonal evaluation is already underway. Vitamin D, functioning more like a hormone than a traditional vitamin, is commonly deficient in elderly men. particularly those with reduced sun exposure, and connects to both testosterone regulation and vascular health discussed earlier. This represents another reasonable low-risk area to include in broader blood work evaluation, given how common deficiency becomes with age and how directly it connects to several systems already discussed throughout this video. Physical activity remains genuinely modifiable regardless of age and connects directly to several factors discussed throughout this video: cardiovascular health, testosterone regulation, and mood. Research on exercise in elderly populations consistently finds meaningful benefit even when activity begins later in life, meaning this isn't a factor limited to men who've maintained consistent activity throughout earlier decades. Resistance training specifically has documented benefit for testosterone support and muscle maintenance in older men, while regular walking or other moderate cardiovascular activity supports the vascular health discussed extensively earlier in this video. Neither requires intense or elaborate programming. Consistent, moderate activity appropriate to individual capability and any existing health conditions produces meaningful benefit, worth discussing with a doctor to establish what's appropriate given any specific health considerations. It's worth directly acknowledging that some elderly men experience minimal change in this area well into advanced age without any specific intervention. This reflects genuine individual variation in how aging affects different men, tied to genetics, overall health maintenance throughout life, and simple biological variation that exists across any human trait. This isn't the expected outcome for every man, but it's a normal documented pattern worth mentioning specifically so that men experiencing more typical age-related change don't assume something is uniquely wrong with them simply because they've heard of other men experiencing less change. Bringing together the practical guidance discussed throughout this video into a simple checklist worth considering: review current medications with a doctor or pharmacist for known relevant effects, request basic blood work covering testosterone, thyroid function, vitamin D, and blood sugar. If a meaningful change has occurred, consider whether mood, sleep, or broader life stress might be contributing factors worth addressing directly. Maintain physical activity appropriate to individual capability, and communicate openly with a partner, if applicable, about any changes rather than allowing assumption to create unnecessary distance. None of these steps require alarm or urgency in most cases. They represent a reasonable, methodical approach for any elderly man wanting genuine clarity about a change, rather than defaulting to either dismissive assumption or unnecessary worry. So here's the bottom line. Stopping doesn't cause physical harm or decline on its own for most elderly men, and testosterone doesn't significantly rise as a result, despite common belief. 3 practical takeaways. Don't assume reduced interest or ability is simply unavoidable aging without checking. Maintain other stress-regulating habits if this specific outlet becomes less available, and raise any accompanying symptoms, fatigue, mood changes, with a doctor rather than assuming nothing can be done. If this addressed something you've wondered about, that's exactly why this video exists. The Iron Age Guide is linked with this video. Thanks for watching, and I'll see you in the next one.